Now we've got Dr. Joe Arms, who's Senior Lecturer at King's, who's Chair of the Psychosocial Oncology Group. And we're particularly pleased that Joe is here because it represents the collaboration rather than the competition between our two groups, the Supportive and Palliative Care and the Psychosocial Oncology Group. So, Joe.
Thank you very much. It's a real pleasure to be here, and I'm going to be talking about the title of my talk's Written on the Body, Assessing and Meeting the Needs of People Living with and Beyond Cancer. And it's been interesting hearing all the other talks and discussion because some of the things I'm going to talk about you've already touched on. What I'm going to do in the session is first of all talk about, review the prevalence and predictors of unmet need, and then go on to identify alternative methods for capturing and using patient-reported outcomes, and then discuss novel methods for delivering interventions. So the treatment of cancer is an increasing success story. In 2010, there were 2 million people who were estimated to be living with or beyond cancer, and that's predicted to double over the next 20 years to 4 million. And Macmillan, in their Roots from Diagnosis work that was published last year, have attempted to identify the different patterns of survival using hospital episodes data. And so they've identified a group who they have judged to have limited survival, a group who have limited to moderate survival. So, for example, for breast cancer, that would be people who are 1 to 7 years following diagnosis, and a group who are surviving for longer than that. And within that classification, they've attempted to differentiate between the different groups. So they've identified people who have complications of cancer, and by that they mean metastasis or recurrence. There's people who they've identified have been admitted for other reasons that they think are related to their cancer treatment. And then there's people who have no ongoing effects. And what you can see for the different diagnoses is that there's a different pattern of survival across those 7 groups. And that's particularly the case for lung cancer. So this is the skeleton of a Roman man who lived in London in 2000 AD, and although it is about 20,000 years old, it still bears the signs of extensive multiple myeloma. And we know that following treatment for cancer, that patients go on to experience other secondary conditions, such as lymphedema, infertility, cardiovascular effects, and sexual dysfunction, as was alluded to earlier. And we know there's growing evidence that some of those secondary effects are a direct effect of treatment, as this position paper about cardiovascular side effects illustrates. There's also growing evidence that the impact of these conditions has a huge impact on people. So in this systematic review looking at treatment-related impairments in breast cancer, people were experiencing a huge range of problems that related to range of movement. There's also growing evidence of the impact that alongside the recognition of late consequences, there's also growing research looking at patients' experiences. So in 2011, a large survey was undertaken, results were published from a large survey that was undertaken in England, looking at almost 5,000 people, 1, 2, 3, and 5 years following a cancer diagnosis. And so people with breast, prostate, colorectal, and hematological cancers were surveyed. And what this shows is that a significant proportion of people were experiencing both physical and psychological symptoms. Most notably, 30% reported that they had pain, around 70% said that they felt tired, and over 80% said that they had fears about their cancer recurring. And this translates into difficulties in functioning in everyday life and recreational activities. So what we've got is not a picture of people finishing treatment and slotting back into their everyday life without any problems. These people are living with cancer rather than beyond it, because cancer's still writ quite large on their bodies. And I think this notion's encapsulated quite well in this quote from this survey that says, "I'm thankful the surgery allowed me to live, and I try to remember that when debilitating pain makes me want to die." So that survey used quality of life measures, and these typically ask people about the presence and severity of symptoms. But there's an area of research now that is starting to ask people about their needs for whether they have a problem and whether they need support for it. And these measures are typically look at supportive care needs. And in the UK, 2 large studies have been undertaken that show that both in the short and long term, a significant proportion of people are experiencing substantial problems following their treatment. So this and the next slide present results from a systematic review of 57 studies looking at supportive care needs of patients, and it shows the prevalence of unmet needs, and it shows them over time. And what you can see is that typically people's needs increase with treatment and then decrease once treatment's finished, although those needs vary according to whether you're asking them about their physical needs or their psychosocial needs. However, if we look at information needs, you can see that there's a quite different picture, that people's information needs increase with treatment and they don't decrease once treatment's stopped. Rutter thinks this is because people have different information needs at different times. So they, and this is supported by, and they created this typography here on the right of different information needs that people have. So, and this is supported by findings from a study by Schlegel et al., who say that around diagnosis, people need information about treatment and whether their cancer might have spread or not. And then once they start treatment, they need information about everyday functioning. So as we gather more information, it's becoming clear that there's a number of factors that are associated with people experiencing high unmet need. In longitudinal studies, it's been shown that if you have high unmet need at one time point and someone assesses it again at another time point, that is predicted you are likely to continue to have unmet need. And this tells us that if we don't address patients' unmet needs, they don't go away on their own. We also know that younger and older people are at increased risk of having unmet need. There's a complex relationship. It's been proposed there's a complex relationship between fear of recurrence, symptoms, and unmet needs. And so it's been proposed that poorly managed symptoms can really lead to a reduced quality of life. And this means that the person perceives that the services they're receiving don't meet their needs. At the same time, uncontrolled symptoms can act as a constant reminder to people that they have cancer, and therefore the symptoms that they're experiencing, they perceive that they wonder whether the symptoms they're experiencing are indicative that their cancer's returned. So then they start to worry about it. We also know that comorbidity, cancer patients are more likely to also have another condition, a comorbid condition. And it's estimated that around 50% of cancer patients have another comorbid disorder. So this slide shows results from the Macmillan Roots from Diagnosis work again, and it shows the prevalence of different comorbidities in people with breast cancer, but they also present it for lung, hematological and brain cancer as well. And what it shows is that both at 1 and 5 years following a cancer diagnosis, women were at increased risk of respiratory, circulatory and genitourinary comorbid disorders. They were also 30% more likely to get a new primary cancer diagnosis. And on this slide here, it shows us, it's a study by Bennett et al., and they're looking at comorbid disorders in relation to deprivation, so socioeconomic deprivation, and cancer's here at the bottom. And what it shows us is that for the people who are more deprived are more likely to also have a comorbid disorder. And those comorbid disorders are typically coronary heart disease, depression, anxiety, and COPD. So I've talked a bit about unmet needs, but if we talk about the impact of late effects on unmet needs, then Triana in Northern Ireland has attempted to estimate the number of people who are experiencing late effects, and they've asked them to also complete a supportive care needs measure. And what this shows us is that those people who have one or more late effects, that's the red bars, are more likely to say that they have unmet needs in relation to concerns about their cancer coming back, in relation to a need for up-to-date information both for themselves and for their partner, and that they feel that their care could be better coordinated and that they'd benefit from a key health worker. If we then look at the impact of late effects on cancer, once again, people with one or more late effects is in the red bars, and they asked people to fill in the SF36, which is a measure of physical and social functioning, and the lower the score, the greater the disability. And you can see that the people who have one or more late effects across the board have report greater health impairments. And what impact does that have on health services? Well, in this study, patients reported that they used health services more, both in general practice and in the hospital setting. So we can see that there's a substantial burden of having late effects and late consequences of treatment, both on the person and the healthcare system. And Nada Khan in 2011 used the general practice research database and showed that women with breast cancer were more likely, made more visits to their GP in the first 10 years following a cancer diagnosis as compared to a non-cancer group. And in the Netherlands, Heinz et al. Found that the most common reasons for people with cancer attending their GP was either acute infections such as a chest infection or a urinary tract infection, or acute symptoms such as pain and fatigue. Interestingly, they made little mention of psychological problems or fear of recurrence. To date, little attempt has been made to calculate the cost to the NHS of this increased health service usage until recently. And so this is taken once again from the Roots from Diagnosis work. But using the hospital episodes inpatient data, they have attempted to calculate the costs to each of the 3 survival groups that I outlined earlier across the survival trajectory. So for each bar, the lighter green represents the costs in the first year following diagnosis, and the darker green bar are any subsequent years. And I think the thing to note in this are groups 3 and group 6, because these are the 2 groups who are surviving cancer but have late complications. And you can see that there is a substantial financial cost to the NHS. So the evidence is accumulating about the impact of cancer treatment on people who are living with and beyond cancer in terms of their unmet need and the costs to the health systems. But what are we going to do about it? In 2005, the Institute of Medicine in the US published this position paper which outlines 4 principles of optimal cancer survivorship care. And worldwide, across Europe, America, Canada and Australia, there is a move to develop new models of cancer survivorship care, both to improve care that people receive in line with these 4 principles, but also to accommodate the large numbers of people who are now surviving cancer. And this is the model of care that the National Cancer Survivorship Initiative launched quite a while ago now, and I'm sure you're all aware of it. So central to these new models of care is assessment. It's important because it helps identify people who need help, and on that basis, health professionals are able to target scarce resources to people who need them. But we know that there's a discrepancy between what's recorded in what clinicians report in medical or healthcare records and what patients report. And so there's a push worldwide to increase the use of patient-reported outcome measures. And the rationale for this is that it'll enhance communication and patient education, promote joint decision-making, it'll assist with screening for health issues or monitoring for changes in disease severity. There are people who have concerns about it because they feel that it might interact on the clinician-patient relationship because it narrows the focus of the discussion. And this is a big and, because one of the rationales is that it will stimulate better care and improve outcomes, but to date there is little evidence to show that it does. These are the most commonly used patient-reported outcome measures that we use in the UK in the survivorship setting. None of them are perfect, they all have their disadvantages, and to date they've largely been used in a paper format, and that has really hindered their use in routine practice because there are issues about scoring them at the time that they've been given to people and how to interpret the information that you then get from the once they're completed in a real-time consultation. But there are some solutions. Computers are one of them, and smartphones are the other. And I'm going to talk about a few studies, some of which are on the NCRI portfolio, that are attempting to look at the feasibility and cost effectiveness of using these interventions. So the first study has been conducted by Penny Wright at the University of Leeds, and she developed an electronic patient-reported outcomes online system for reporting patient-reported outcomes. So patients were asked, so there were 2 parts to it. There's something called the Q tool, which is a dedicated database for password-protected database for patients to complete online assessments. And then there was a tracker for checking patient activity on the Q tracker. They tested the technical and clinical feasibility of using it in 2 NHS settings over a 2-year period and recruited just under 700 people to this study. Now that represented 55% of the people that they asked to participate, so just over half of them. The main reasons for non-participation at that time were to do with issues around using information technology. But what they found at the end was that two-thirds of all the people recruited had completed all 3 assessments. They were assessed on 3 occasions at 6, 9 and 15 months. And that they said that they found it easy to use and that they would have continued using it. Apparently there was very little administration burden and there were few technical problems. And so Penny and Galina Velikova, both at the University of Leeds, have built on this work, and they've expanded they're still using the Q tool. I should have said actually with the EPOCS work, the questionnaire data was then linked to regional cancer registry data, so they were able to link to clinical records in some way. In this study, they're actually linking to the electronic patient records. So it's allowing real-time assessment of people's symptoms while they're having chemotherapy. And that goes straight into the electronic patient record in the acute hospital trust. So patients complete the assessments online at home. If the symptoms are mild, they get self-management advice. If the symptoms are serious, they're asked to contact their acute trust straight away. An alert is sent to the hospital team as well. There are also patient-reported outcome measures that are being computer adaptive, that are starting to use computer adaptive testing. And what this attempts to do is maximise the information that patients provide when they answer a particular question. So the selection of the next question the patient answers is based on the question that they have just answered. So if they say that they don't have any problems with fatigue, they would not be asked any more questions about the fatigue. They would then go on and answer questions about other symptoms. And the benefits of this are that it increases the precision of the questionnaires, it helps to minimise floor and ceiling effects, and it also helps to avoid asking patients redundant questions. And that's where it is on the website. And there's a similar system that's being developed in the US, so the PROMISE system. But with the advent of mobile phone technology, there is increasing scope to use smartphones. And I'm going to tell you a little bit about a study that I'm involved in with the University of Surrey, which has recently received funding from the EU. And this is looking at the real-time assessment of chemotherapy-related symptoms using smartphones. And so we're conducting a randomised controlled trial to evaluate electronic symptom management using the ASIMS remote technology system. And so what will happen, this is, they get a dedicated handset, and the patients who are randomised to receive the intervention will be given one of these handsets. The other group of patients are randomised to receive usual care. And they're asked to complete these 10 chemotherapy-related symptoms on a daily basis and also take their temperature using an electronic thermometer. And they're asked to record the incidence, severity and bother that they're experiencing. So on the basis of that, scores calculated, and using clinical algorithms, a traffic light grading system is applied. If the symptoms are mild, it's green, and they're sent self-care via the mobile phone device. If the symptoms are moderate, it generates an amber alert, and if the symptoms are severe, it generates a red alert. Both red and amber alerts go directly to the clinician, who also has a handset. And with a red alert, they're asked to respond to the alert within 30 minutes, which means that they need to log into the database that holds more information about what the patient's problems are, and then to contact the patient, assess them, using the clinical algorithms within that database, and then to provide them with advice about what to do. So we're aiming to recruit just over 1,100 people from 5 countries and 11 clinical facilities. And we're looking to recruit people with breast, colorectal, Hodgkin's disease and non-Hodgkin's lymphoma. And we're going to look at both the short-term and the long-term impact of using the ASIMS system. So people will complete assessments at the beginning and midpoint in each cycle of chemotherapy, and then immediately after they finish treatment, and then 3, 6, 9, 12 months afterwards. And we're going to be looking at symptoms, quality of life, anxiety, supportive care needs, self-efficacy, and work limitations. Now, this study, we're just waiting for R&D approval which has taken a long time, to start the pilot study, but hopefully that will be soon. So it's watch this space. So in terms of doing assessments using information technology, there are challenges to doing it. And whilst they hold a lot of promise, there are challenges. And the big questions are, who should be doing it? When should we be doing it? What training do people need to do it? And it's time consuming. I've seen EHA, so electronic holistic needs assessment, using a tablet done in the outpatient setting, and it still requires someone to go up and do it with the patient. And then there's issues around scoring and interpreting results, and then there's huge technological difficulties. But so more research is needed, looking at the impact on outcomes, remote monitoring. That's an area that could really benefit from using patient-reported outcomes. I think the key area where there's been very little done is using assessment in screening for and identifying late effects, particularly in the adult setting. Just quickly going to talk about delivery of supportive care interventions, and we'll talk about the evolution of fatigue interventions, and most of them I've been involved in, using different technologies. So we started off with face-to-face interventions. Both myself and my colleague Emma Ream developed and tested randomised one-to-one face-to-face interventions for fatigue. I used MI and elements of CBT, and Emma used motivational interviewing and also coaching. And what the intervention comprised is shown here on this slide. And what we found was that it was effective at improving physical fatigue, physical functioning, and reducing fatigue-related distress. However, it's costly and it's really time-consuming, and it's limited to the people who are able to come to the specialist centre where you're delivering it. So Emma had, and towards the end of the noughties, it became clear in the current economic climate that this isn't a viable model for delivering interventions. And so Emma did some development work and looked at translating her intervention into a telephone intervention and found it was equally effective. So we were awarded a knowledge transfer partnership to adapt the telephone intervention for use by Prostate Cancer UK's telephone helpline nurses. And so 76 people were identified via the helpline and randomised to receive either Get Back on Track, which is the name of the support intervention that was developed, or allocated to a waiting list control, and while they were waiting for the study to end, they were given Macmillan's Coping with Fatigue booklet. And what we found was that there was statistically significant improvements in global fatigue, fatigue severity, and fatigue self-efficacy, and a trend for improvements in distress, social functioning, and depression. But once again, this is, whilst it improves the equity of access issue, it's still a one-to-one intervention, and it's still relatively costly and time-consuming. And so I was involved in a study that was led by Claire Foster in the Macmillan Survivorship Research Group at Southampton, who have developed an online web-based intervention to enhance self-efficacy to manage problems associated with cancer-related fatigue. There were 5 sessions delivered over 6 weeks. They recruited more patients than they intended to at 12 centres, and what they found was a trend towards improvement in fatigue self-efficacy. Patients found it really, they reported that they found it easy to use and beneficial. So I wanted to, because I am going to finish now. So the conclusion in terms of intervention delivery is that online interventions do offer the opportunity to reduce costs. They reduce the time that it takes to deliver interventions. Equity of access isn't an issue. However, because there isn't a patient-clinician interaction, there's little opportunity to develop a therapeutic alliance, and engagement therefore tends to drop off during intervention delivery. So there's some ideas here for future research. I think the key issue in terms of any intervention is that one size doesn't fit all. And so therefore the key thing that we all need to learn in our research is what works best for who and when, and we need adaptive trial designs to do that. So I'm going to finish, and I'm going to go back to the beginning, and the quote is taken from a book by Jeanette Winterson, who says, "Written on the body is a secret code. It's only visible in certain lights. The accumulations of a lifetime gather there. And similarly, the effects of cancer and cancer treatment are encoded and accumulate, leaving a lasting impact on the person and their body. And these can only be read by those who know how to read the signs and are motivated to do so. And this can be aided by using web-based and digital technology to capture patient-reported outcomes and deliver interventions designed to meet their needs." Thank you.
Thank you so much, Joe. It's very poetic as well as a very scientific paper, and it's interesting how it brought together so many of the themes we already heard. For instance, John Snowden talking about the need for assessing some of these new techniques, such as not new, but mindfulness, etc. So I was sort of moving along because I wanted you to have some time for any questions. Are there any questions from the audience? Need to wait for the roving microphone. Can I just check while we're getting these? Do you find any difference in uptake between men and women in these studies using things like smartphones? Because the sort of gut feeling I'd have is that would appeal to men, for instance, or does it not matter about gender?
I haven't started yet.
Haven't started yet. Okay, good answer.
But I think someone here from Leeds, are they?
Yes, from Leeds. Get the microphone.
It's more age-related rather than sex-related. We tend to find that young people are more internet savvy.
Younger people rather than related to gender, right? Okay.
Be a difference in
Okay, thank you. Any questions from the floor? Is there anybody? Yes, Matt.
Joe, can I ask you about the issue of unmet need assessment? And just to ask, really, I mean, I guess being a sort of a natural cynic, one might say that it's not a great surprise that patients who assess themselves as having high levels of unmet need also assess themselves as having high levels of symptoms. And I'm just not sure how you control for people's own perceptions of their needs and their symptoms. That's to say, we know that there are people who are very stoical and who will say, no, they don't have any unmet needs and they don't have any symptoms, who maybe do. And conversely, there are people who will just say yes to everything. And I'm just not sure how you go about making those sort of controls. And in the data that you were showing us.
I suppose I'd ask you the question is why you're thinking that people aren't.
Well, because I'm a doctor and I spend all my time trying to assess people's needs.
Because when people tell me they've got a need, I believe
and I
them.
know that people's perceptions of their needs aren't necessarily always perfectly correlated with my perceptions of their needs. Now, of course, I may be wrong, and I would absolutely accept that. But what I'm saying is that it's pretty clear that, to me at least, that we aren't necessarily the most reliable reporters of our own needs, and myself included.
I'm not sure how to respond to that question because actually I think if patients are saying that they've got a problem, then we should be responding to that perception that they've got a problem.
A response from there?
I'll answer that one, that's all right. I think it's to promote conversation between the clinician and the patient. If a patient self-reported it, we wouldn't expect a clinician to just take it at that. It's to try and, there might be where the patient's in a consultation and they don't want to bring something up face to face, but if they're actually reporting remotely and the physician can see that, it can prompt a conversation, and then it's a discussion between the two of you rather than you making that decision alone as a patient.
Right, I absolutely agree with that. And I get the point. I'm just worried about the people who don't report, that's all. And in a sense, I'm more worried about the people who are stoical and who just say, I'm fine.
Yeah.
And I get an awful lot of those because I have a predominantly male Yorkshire clientele, and I have to say that's the natural response to any question. So that's sort of what I'm
But
coming
it'd be interesting to see if those group of patients would feel more comfortable doing it remotely than actually in consultation with the clinician.
Well, I'm involved in E-Rapid, so hopefully I'll get a feel.
You do have 50 patient actually.
Any more questions out there? No? Okay, well in which case, thank you very much, Joe.